Good morning, and thank you for joining us. I am Sue Derkens. I'm one of the co-CEOs at Lamprey Healthcare. I am joined here today by several of New Hampshire's safety net providers and patients to implore the legislature to invest in New Hampshire's Medicaid program. First, we would like to thank the legislature for restoring our Medicaid rates. We ask the Budget Committee of Conference to protect our safety net system and the residents who rely on us to keep them healthy and thriving by funding the state's Medicaid reimbursement and eliminating the cost sharing and work requirements for low-income residents that are currently included in the state bills. Medicaid is health insurance, ensuring over 187,000 residents in nursing homes, low-income adults and children, pregnant women, veterans, and people with disabilities. It covers essential services like doctor's visits, prescriptions, mental health services, cancer treatment, and long-term care. And it helps our residents access the care they need to get healthy, to stay healthy, and to thrive in our communities. Along with the positive health outcomes, Medicaid also supports New Hampshire's economy. It benefits our state budget and strengthens our workforce. Like Lamprey, our entire safety net system is reliant on Medicaid reimbursements to serve its patients. Lamprey Healthcare is a federally qualified health center. We serve roughly 17,000 patients. We provide primary care and wraparound services regardless of the ability to pay. Our services are focused in 40 different communities within Rockingham, Hillsborough, and parts of Stratford County. As a health center, as I mentioned, we serve all patients regardless of their ability to pay or their insurance status. Currently, we have 43% of our patients are commercially insured, 24 are insured by Medicaid, 14 are insured by Medicare, and 19% are uninsured. Lamprey Healthcare has been caring for patients for over 50 years, and we have seen the damage that can be done to our patients and our budget when Medicaid eligibility changes are made. During the most recent Medicaid unwind, more than 1,000 of Lamprey's patients lost their Medicaid health insurance. They are still our patients, and we receive little to no reimbursement for their care because they simply cannot afford to pay. In 2019, New Hampshire implemented a Medicaid work requirement, and nearly 20,000 Granite Staters were poised to lose their Medicaid health insurance before the governor stepped in to stop the implementation. If our patients lose health insurance because they have problems submitting the paperwork associated with the work requirement or paying their Medicaid premiums, they will still be our patients. Again, the problem is we will lose the reimbursement for the services we provide to them. Our losses will drastically increase, and we may be forced to reduce services in order to keep our doors open. Our ability to care for our communities, for your constituents, for our friends and neighbors requires the state to continue investments in programs like Medicaid by eliminating the work requirement and cost sharing provisions and fully funding New Hampshire's Medicaid program. Now I'd like to turn the podium over to Joe Freeman, and he is from Community Crossroads.
Good morning. My name is Joe Freeman. I am not affiliated with Community Crossroads as an employee. I am from a vendor agency that works with Community Crossroads in providing long-term care supports for children and adults with developmental disabilities. Barbara Strakowski, who is from Community Crossroads, was planning to be here, but had a family matter that prevented her from coming. So thank you for having me. I have been with the Kim A. Nichols Center for approximately 40 years. I've seen the the ebb and tide of our give and take of budget years, but became very concerned, obviously, this year with the threatened Medicaid cuts, the no funding of the wait list, and then limited funding for room and board, which is a very crucial issue here in the state of New Hampshire, just in a general sense with housing, but especially for people with developmental disabilities. I also want to thank the legislature for the work that they've done in the budget. I know that they have listened and they have restored much of the desire of the developmental disability community for putting back the 3% Medicaid cut, eliminating that, funding the wait list, and also giving a lot of discussion to the room and board deficit. As a nonprofit agency, the Kimmy Nichols Center has endured room and board deficits for the last 2 years amounting to $500,000, approximately $475,000. But I know their legislature deserves a lot of credit in the recent days. Medicaid rates, the threatening of Medicaid rates being cut, or Medicaid rates being cut, really strike at the heart of the vulnerable population that we support here in New Hampshire. Cuts threaten access to health care. I'm also a registered nurse, and I coordinate health care for a number of our individuals who are experiencing intellectual or developmental disabilities, but have myriad health issues such as seizure disorders, orthopedic needs, and mental health services. Right now, it is very difficult to find many providers who will accept the Medicaid rates as they are, never mind for a cut. So that would drastically impact all the individuals that are supported by Medicaid for their health care. Any cut also affects the workforce. I'm sure you're well aware New Hampshire has a workforce deficit for people in the helping professions. Not only long-term care for people with disabilities, but also for the elderly and other caring professionals. Cuts also cost more in the long run. If we're not able to support these folks in their communities with good healthcare services or with adequate housing and affordable housing and funded housing, it's going to put a burden on hospitals. It's going to put a burden on families who have just been able to sustain their individuals at home, but can no longer do that given their own ages or their own socioeconomic standing. They need to work. The human impact is real. A number of our individuals cannot live independently. They need staff. Staff need to be paid. Agencies need the funding. So individuals with disabilities work. They are working in the community. They volunteer in the community. They're great consumers. They love going out to eat. They love going bowling, doing different things. They are supporting the economies where they live. We need to support them. Gone are the days of Laconia, the Laconia State School, where people were just warehoused for their needs. We need to stand behind the fact that New Hampshire has a very good community support system for people with developmental disabilities. We just need to support it. I also want to make sure that we're taking the right moves and getting the right information to our legislators, because we need to have more stability with the Medicaid process. We need to be making sure that people who are experiencing disabilities with the work requirement aren't having to be jeopardized by that, because if they lose Medicaid, they lose the support system that is allowing them to work. So it's really important that everything is kind of looked at as far as its connections. And we should also lead with compassion. This state has led with compassion. Again, I've worked in the state for 40 years. I'm very impressed with the individual attention that's given to details, the commitment by agencies such as my own agency, by the area agency such as Community Crossroads, and just the New Hampshire population in general. So thank you very much. And I want to introduce Dr. Melinda Asbury, who is from Monadnock Family Services.
Good morning, everyone. My name is Dr. Melinda Asbury, and I'd like to tell you just a little bit about myself so you can understand where I'm coming from and the purpose that I am standing here before you today. I am the Chief Medical Officer and the Interim Chief Executive Officer of Monadnock Family Services, which is one of the community mental health centers in New Hampshire serving the Monadnock region. I'm also the Chair of Psychiatry at one of the largest regional hospitals in New Hampshire. I have an MD and I studied at Duke University School of Medicine, and I also possess a PhD in the field of neuroscience. I have spent my career caring for individuals with serious and persistent mental illness, as well as substance use disorders. So it is on these grounds that I speak with you today on behalf of our patients and behalf of the New Hampshire Community Behavioral Health Association. This association represents the 10 community mental health and certified behavioral health centers in New Hampshire. And we stand in solidarity today as we urge policymakers and the community to reject the Medicaid work requirements. We urge you as community members to let your voices be heard, to rise up and be the advocate and the voice for those who are more vulnerable. I want to start by saying as well that I want to speak to you from the context of a clinician and also from a scientist. And to inform everyone who doesn't know that mental illness and substance use disorders, those are chronic brain diseases. And as such, they have a unique hallmark. These are not curable diseases, but instead, these are diseases that have a hallmark of periods of recovery and periods of relapse. And a Medicaid work requirement that is mandating work across the board simply is not going to work, because these diseases do not work that way. People have times of health and people have times of illness, and it is impossible to predict where someone is going to be at any point in time along their recovery journey. So Medicaid work requirements in that way will not work. The fortunate piece is that we do know what works, and that is an evidence-based, research-rooted program called supported employment. All 10 community mental health centers have a supported employment program, and many of them also have a supported education program, wherein the purpose of these programs is to return people or get people into employment as soon as they are healthy enough to do so, and the same with places of education. We know how to do it. We've been doing it for years, and that is the way that it works. The sad part about this is that if people do have times that they're not able to be employed, and they are able to fulfill the paperwork and bureaucratic burden of doing such for an exemption, then they will lose access to care. And thus they will lose access to the very programs meant to support them, supported employment. To me, that does not make sense. I've heard a lot about exceptions. Well, there's exceptions for individuals with this or exceptions for individuals with that. And in theory, these sound good, right? It's great to have an exception. But do not let that fool you. Do not let that be a safety blanket. Let's play this through just a little bit. So if someone is able to get an exception, then that means that that person has to be so seriously disabled that they are unable to work, right? So someone who is unable to work, what do we think the likelihood is that that person is going to be able to do this amount of paperwork and follow the process necessary in order to qualify for an exemption? To me, that just does not make sense. Another piece of this exemption is that the burden of proof does fall on a patient who at that point in time may not be capable of advocating for him or herself. And the other burden will fall on community mental health centers to consistently have to approve work hours or apply for exemptions and certify that an individual at that point in time indeed cannot work. And what that will do is drive resources away from that very individual and all of the other individuals that we serve in our community mental health centers. We already know, and Sue spoke to the fact that a lot of our centers provide uncompensated care already, wherein we provide services to individuals who aren't insured or who are underinsured. Alone, the community mental health centers equated about $16 million in uncompensated care last year. And we cannot shoulder that financial responsibility. This would only make that worse. And if that worsens, then we will be in a financial crisis, a financial critical point, and we will probably need to stop providing services to a group of individuals. We just won't be able to afford it. And this, refusing this and rejecting this will make that probability much less likely. In sum, work requirements are a net negative for behavioral health systems and for the patients that those behavioral health systems serve. The community mental health centers, for these policies, shift away our precious clinical resources and push them towards administrative burden. This also stigmatizes and marginalizes the population that we all have spent our careers and our advocacy and voices for protecting. We do not want individuals to have to come and shout about the fact, hey, you know what, I can't work right now. Give me this piece of paper that says I cannot work, because that is already confidence crushing enough. Why do we have to belabor that point? We urge policymakers to reject Medicaid work requirements and protect access to care across New Hampshire's most vulnerable residents. Recovery depends on reliable and predictable and supportive mental health care, not on bureaucratic red tape. Thank you. I would now like to introduce Christina Emant.
Good morning. My name's Christina Emant, and Medicaid made it possible for me to go to Hope on Haven Hill, a treatment when I needed it the most. Every other treatment center I tried would only allow me 28 days, nowhere near enough time to find recovery from substance use disorder. Without thousands of dollars to continue treatment, I was denied extended care, left without aftercare, and eventually found myself incarcerated. But Medicaid changed that. It allowed me to stay at Hope on Haven Hill for 6 months, time I desperately needed to focus on my recovery and the health of my child. I gave birth to my daughter, graduated from Hope, and moved into their sober living facility, where I lived for 2 years. Medicaid ensured that I had access to therapy and critical medical care without worrying about treatment cost. It provided me a foundation to rebuild my life. Later, I secured employment, private health insurance, but when I was laid off, I had to return to Medicaid. It helped me again, allowing me to stay afloat until I found my new job at SOS Recovery. Medicaid is not just a program, it's a lifeline. It allows families like mine to survive, to recover, to contribute to our communities. Losing it just isn't an inconvenience, it's the difference of stability and crisis. We need to protect and expand Medicaid, not limit it. Access to affordable health care should not be a privilege, it's a lifeline. I urge lawmakers to please support the Medicaid program. The participants I serve at SOS rely on their health insurance for basic medications and appointments to support overall wellness. Please think about the opioid crisis right now and all the people who need insurance for services. I was denied for treatment for not having insurance many times. The work requirements for individuals are extremely hard to sustain when you're trying to just go to IOP and stay in sober living. To keep these requirements and stay in treatment. Work requirements that are too strict could lead to disenrollment in Medicaid, thus cutting off access to life-saving SUD treatment, included Medicaid-assisted treatment. This can lead to serious consequences such as increased risk of overdose and emergency inpatient visits. Individuals in recovery frequently encounter challenges when seeking and retaining employment because of gaps in their resumes or previous substance use problems. Work requirements can further exacerbate the stigma and discrimination faced by individuals with SUD, making it even harder for them to find employment and maintain their recovery. Imposing rigid Medicaid work requirements without adequate consideration for unique challenges faced by individuals in recovery can undermine our efforts to achieve and maintain sobriety, hindering my ability to access essential treatment and support services. Now I want to introduce Andrew Harmon.
Sarah. Good morning. My name is Andrew Harmon. I am, as you can probably tell from the cane, a person with a disability. I live in a very rural town called New Hampton, New Hampshire, where I rent, and I currently get disability insurance and Medicaid, which covers a number of my medications for my diabetes. It also helps give me a discount on one of the tools I use to manage the diabetes because of a genetic disorder I have. I can't use a regular test strip, which are very expensive. If you've ever seen the commercials for the Freestyle Libre by Abbott, that's what I use. And it cost me about $80 a month after the discount. The current plan to impose cost sharing would severely impact my ability to live where I do, because my work that I do as an independent contractor with a company out of Canada is completely remote and completely based upon assignment. I perform accessibility testing for a number of their clients. And so I never know what my actual income is going to be from month to month outside of my disability insurance. So I will never be able to plan for if they go with the up to 5% of my income. I've had some months where I barely get a little bit more than the disability insurance. I've had other months where I've made almost $500 on top of the insurance. So I would never know how much of that I need to set aside, nor would I know who I would pay it to. I would also be paying a lot more in premiums on top of that if the current plan stands. Right now, I believe they're trying to increase it to $4 per item, but I don't know if that's on any specific item or if that's on categories. I've yet to see any specifics on that. So that would be a huge problem. And finally, if the Medicaid, if I couldn't meet the requirements, would I lose my Medicaid entirely? If so, I would be paying a lot more, probably my entire money that I make from my job, probably a good portion of my disability insurance on top of that, which means I wouldn't be able to afford my rent, I wouldn't be able to afford groceries, and I definitely wouldn't be able to afford if I needed to travel because of how rural where I live. The only option is volunteer driver programs partially funded by Medicaid. Also, occasional Ubers if the driver happens to be in the area and if the driver decides to take my ride based on how much it might cost. So this cost sharing program is going to be a huge impact. I hear them say there might be another way to do it where it's a flat amount, but even if it was $60, I can cover that. But then if an emergency comes along, suddenly I have to pay $60 plus a trip to the emergency room or having to go to see a specialist up in Lebanon, which means I have to get transportation. So this program would horribly impact people with disabilities like myself, and some of whom don't even have the job that I do. So thank you very much. And now I'll turn it back to Ms. Derkens.
So first off, I wanted to thank our speakers and especially our patients who've been willing to share their stories. They're very inspirational. So as you've heard repeatedly, reductions to Medicaid reimbursement, the work requirement, the cost-sharing provisions included in the state budgets will only shift the cost and burden of healthcare to other parts of the system. Patients will forgo preventative and follow-up care. And it's not only the care that takes place in an exam room. They would lose access to diagnostic tests, imaging, even medications. And all of this will lead to poor health outcomes, increased ER use, increased hospitalizations, and the cost for more expensive health interventions that probably wouldn't even be necessary otherwise. And this won't just affect people who have who are uninsured. This is also going to affect people who have health insurance. Insured patients are likely to face longer waits in ERs because uninsured patients who don't have access to health centers like ours may be forced to access primary care through an emergency room rather than a traditional primary care office. So investments in New Hampshire's Medicaid program are critical to the safety net system's ability to provide care to Granite Staters, and it's critical to New Hampshire's economy. We ask that the Budget Conference Committee support the Senate's position on Medicaid reimbursement and eliminate the work requirement, premiums, and cost sharing that undoubtedly will cause people to lose health insurance, experience poor health outcomes, and damage our economy. So I would like to invite the speakers to come up, and we would be available for questions. So does anyone like to begin with a question?
I have a question.
Sure.
In addition to the committee of conference meeting upstairs, Medicaid is also under attack in Washington, D.C.,
Right.
where apparently just yesterday a new plan was advanced in the Senate to increase the work requirements for the already disastrous House budget. So I'm curious what you are hearing from Governor Ayotte about her. Is she advocating with Republicans in Washington to try to beat this back because of the effect it's going to have in New Hampshire?
I can't really speak to what Governor Ayotte is doing. I hope so, that's for sure, but I can't say for sure. I don't know if anybody else might know the answer to that question. Christine, no.
If you do, come talk to me.
Yes, okay, thank
Thanks.
you.
I will say that I believe Governor Ayotte has been an ally thus far to mental health services and protecting Medicaid. So I can hope that Governor Ayotte will continue in her mission to be an ally and support this care.
I agree, and I think she is taking time to learn about who will be affected by all of these changes as well. Thank you. How about other questions? Okay, if there are no further questions, thank you all so much for your time, and thank you to all the speakers.
Thank you.
Absolutely.